All right, so welcome and thank you for attending today's event organised by the EMCR committee of the ANZSSFR. I'm Jack Delavia, I'm the chair of that committee. First of all, I'd just like to acknowledge that I'm joining this event from the lands of the Whadjuk Noongar people, and I acknowledge the traditional custodians of the various lands on which we all work today, and Aboriginal and Torres Strait Islander people participating in the event, and I pay respects to elders past and present and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the land and waters. Thank you to the EMCR committee depicted here who helped organise today's event, and you can find more information about what we do here at the bottom of the screen. And I'll see if Solomon's online. We might skip past this. So Solomon's the president of the society, who's just going to say a few words to open the webinar, but given the delay, we might skip past that and get started. Just a couple of quick plugs. If you're not already an ANZSSFR member, you can join here, and we have a current discount available till the end of the month. So please consider joining, and you would have seen more information about that in your emails. We're also organising a symposium for later in the year in November for HDR and EMCRs to submit abstracts to present in that session. So again, we'll provide more information about that shortly. Just some housekeeping. Please keep your video and microphones off. During the session. If you have any questions during the Q&A, you can either raise your hand to ask it live or type it in the Q&A or the chat. So we have three excellent presenters today. So we're starting.
Maybe you thought you bought it.
Itamar Levenger, Dr. Peggy Cawthorne, and Dr. Jessie Zanker, who will present on different perspectives. So starting with the mechanistic perspective, followed by epidemiological, followed by a clinical perspective, and then we'll finish with a panel discussion chaired by Dr. Ben Kirk. All right, so without further ado, we'll get started. So Itamar, if you want to share your screen.
Yes, I can't. Can you just give me permission? Currently, I don't have permission to share my screen. Yep, all good. Yeah. Just give me a second. All right, can you see it? All good? Great. I'll take it as yes without an answer. No, thank you very much for the invitation to come and present here about the link between sarcopenia, osteoporosis, and frailty. And I will take it more from the mechanistic point of view. Just because I'm aware of time, I will run through my slides a bit quicker than I wanted. Lucky, yesterday I had to cut my slides from 30-something to 16, so that will help a bit. But if there are any questions or something is not clear, please ask me later or send me an email. So I'll just start, not to waste time, just to make sure that we all on the same page. And for some reason I can't see the top of the thing. To make sure that we're all on the same page with definitions. Sarcopenia. We talk, irrespective of the definition that people use, the main characteristics is low muscle mass, low muscle strength, and poor physical performance. Osteoporosis, we are talking about low bone mineral density, lower than -2.5 T-score, so -3, and so forth. And frailty is, we are talking about a bit more consequences of sarcopenia, which I will touch a little bit later, including unintentional weight loss, low physical activity, exhaustion, and a combination of several of those risk factor phenotypes having the diagnosis of frailty. Can I just please ask, if you're not talking, which means it's only me, can you please just mute yourself? Thank you. There are some background noise. So that is just to set up the scene of what we're going to talk about. And as far as my concern, and again, I'm happy for other people to have their own opinion, there are two main reasons for all three topics of sarcopenia, osteoporosis, and frailty. One is aging. So the fact that we have an aging population, I had another slide to show you in regard to how aging increased over the last 4,000 years, but we know that people now live above the age of 55, which was the average for many, many thousands of years. And because of recent advances in technologies and medications and things like that, and medical treatment, people live longer. The main issue is that people live longer, but they're also more sedentary. So because of the development of technologies and other, people are more inactive, particularly, again, above this age of 60, give or take. This is data from Australia. Almost 60% and more of the population are inactive, particularly above in the older adults. And unfortunately for us, in the last 15 years, despite all the health promotion, despite all that people know that exercise is good for them, we couldn't increase the number of people who participate in exercise, and still the vast majority, almost 70%, 60 to 70%, are not engaging in enough physical activity, which we know that it's a key for the prevention of sarcopenia and also osteoporosis. So we know that exercise is medicine, and probably exercise will be the best treatment for all three of those phenomena that we just described. And it has a wide range of benefit, not just for bone and muscle, but for other organs. The problem is that if people are not doing exercise, as we saw in activity, you cannot have those benefits. And as such, some people think, well, if we can understand the pathway by which exercise can improve health, maybe we can harness that into a pill. So to design medical treatment or drug treatment to mimic exercise. We know that this is probably will be very difficult to capture all the benefits of exercise in one pill. But that's the idea. So we know that both aging and physical inactivity have a substantial detrimental effect on skeletal muscle, and particularly the loss of muscle mass and function. We have a substantial reduction in type 2 fibers. These are the fibers that contract very quickly. So if someone is about to fall or sleep, that's the one that needs to protect us. And if we have a reduction in those fiber types, so we are much slower in our responses, so increase the risk of falls. But we have also less capacity to generate energy because our mitochondria, which is a powerhouse, if you like, of the body, doesn't function as it should when we are young, particularly if we are not involved in exercise. So there is a wide range, including resistance, anabolic resistance. This is inadequate adaptation to exercise and protein, again, with age. So all that actually expose ourselves to a substantial reduction in the muscle quality when we age, particularly if we are inactive. So in regard to some of that mechanism, we know that those disuse and physical and age, as we saw, that's caused to a reduction in muscle mass. Another problem is that there are adipocytes, or our fats, start to infiltrate into the muscle. And that's why we have also a reduction in the contraction capabilities of the muscle, which it's difficult to generate forces. Some people call that inflammaging. This is the increase in inflammatory markers, such as IL-6, TNF-alpha, but there are many more. And those inflammatory markers are after that can cause a secondary muscle deterioration, because they have the capacity to change the balance between muscle protein breakdown and muscle protein synthesis towards the breakdown. So again, there is like a vicious circle that we are less physical active, we have less muscle, we have more inflammation, which also affect less muscle. So we need to stop this cycle. And the increase in inflammation, it's not just in the muscle, it's also in other tissues but altogether it can actually lead to the loss of muscle mass and function seen in sarcopenia, also lost, which then in turn can lead to muscle weakness, slowness, exhaustion, and unintentional weight loss, which is also due to the inability to absorb the amount of protein needed, lead to frailty, the frailty syndrome. So we can see that there is a mechanistic link between those, particularly those two now, and I will talk about osteoporosis in a few minutes. So what we can see that, so sarcopenia, if we will not treat it early, and we will not treat people who are at risk of sarcopenia, can slowly deteriorate into the frailty zone. And this can be even become more aggravated, more stronger, if you like, in people who live with chronic disease and have poor diet. That can push them into down the frailty pathway even quicker. The good thing, again, currently with exercise, we can reverse it. But whether we can harness that for drug treatment, that it's still not clear. As far as I know, there is no drug that can do it right now. Some of the mechanisms that our body communicates. So we have muscle. We know that muscle now is also can be considered as an endocrine organ, producing what people call myokines, hormones and factors that are released by the muscle during muscle contraction. That's why muscle contraction is so important. And in part, it will affect bone. And this link between bone and muscle, between the muscle and bone can actually strengthen also, can strengthen bone. We know that IL-6, the myokine, has a positive effect on bone and also on other tissues. This is in contrast to what's called the IL-6, the cytokines. We're not going into that now, but there is a direct link between muscle to bone through the circulation. So we don't just have mechanical link or anatomical link, but also biochemical link that can control bone from muscle. And vice versa, Cassandra Smith, as part of PhD, reported that bone in response to exercise, whether it's aerobic or resistance and impact, can actually enhance the release of some of those bone formation and resorption markers. And once in the circulation, some of them have been shown to be linked to muscle performance, glucose regulation, and others, which I will show you in a second. So overall, if we talk about bone, and that is partly how the osteoporosis story going into the picture, is that there is also a very strong link between the bone structure and metabolism and muscle function and metabolism. And we know, again, like muscle, bone in recent years has been identified as an endocrine organ that can release several factors, several peptides, such as anticarboxylate osteocalcin, which we know now has a positive effect on muscle, but also sclerostin, which has a negative effect on muscle. It can cause muscle atrophy. And that's why we're trying to reduce the level of sclerostin in the circulation. But also, I will just show you a couple of slides because of time about rank ligand and the recent development with, and why so many people are so interested in rank ligand in recent years. But these are factors that are released by bone in different stages of the bone remodeling process into the circulation and affect other organs. So what we have done, and this is really in brief, we wanted to see whether particularly two types of treatment. One is undercarboxylated osteocalcin, or ACOC, and whether ibandonate, which is an anti-resorptive agent, biphosphonate, can prevent muscle loss in a hind limb immobilization model in mice, but also then improve the human myotubes. And we took muscle from older adults, age 70 plus. And long story short, the combination of that treatment actually enhance the anabolic signalings, particularly AKT, which again, I removed some of the slides from my presentation, but AKT, S160, and PI3 kinase pathway, all involved in muscle hypertrophy and glucose regulation. So we show that it can enhance that. And at the same time, we saw that we can suppress some of those inflammatory markers that involved in, inflammatory pathways that involved in muscle protein degradation. Whether that will have a clinical implications, we still don't know. But at least we saw that there is a direct effect of bone on muscle, and that maybe treatment that's currently available for osteoporosis may also have some effect on muscle. And just finally, for me, because I'm aware of the time, so I'm just under the pump here a bit. Rank ligand, which is we know involved in bone remodeling, particularly resorption, is also can be regarded as anti-inflammatory, as an inflammatory agent, can acidify bone and enhance and cause bone resorptions. We know that people with osteoporosis have an increased rank ligand activities, but it's not only that. We know that rank ligand also has a direct negative effect on skeletal muscle, and it can cause muscle atrophy, and also on cardiac muscle. It can actually lead to muscle atrophy and death of myocytes, leading to heart failure. So we know that the human monoclonal antibody against rank ligand denosumab been used now for a few years to improve bone mineral density, and it's quite an effective treatment. But there is some recent evidence now that maybe denosumab can actually also improve muscle and insulin sensitivity. This paper was published a few years now, so 4 years ago, by Serge Ferrari group, and they showed that treatment with denosumab can actually improve appendicular lean mass and hand grip strength in animals. And they suggest that maybe human studies needs to be tested. Also, I just finished to say that the human data is with denosumab and muscle mass and function are inconclusive, and some of them are quite low quality. So further studies are needed to show whether denosumab can actually improve muscle mass and strength. And my last comment in regard to that is that many of drug trials that's been conducted to date, even if they showed increase in muscle mass, they had a very, very limited effect on muscle strength and function, which appeared to be a bit more complicated to do, but probably more important for activities of daily living. That's my last slide to try to tie everything together. This is from a paper that is currently under review from CAS, about the review of the literature. And what we have showed is the link between osteoporosis and sarcopenia. There are many, many factors that are affecting bone and muscle simultaneously. And if we can harness some of those crosstalk, some of those hormones that related to this crosstalk, perhaps it will give us a new hypothesis and a new direction to try to identify non-exercise interventions, to try to minimize the risk for osteoporosis and sarcopenia, people who are not active. And if we can stop that, then perhaps we can then prevent the deterioration into the frailty level, which is a secondary to sarcopenia, but much more severe, because you have the high level of exhaustion and the unintentional weight loss, pushing people then maybe to muscle cachexia, which is a bit different, and we're not touching it here now. But this is really in a nutshell, and I'm so sorry that I have to talk a bit fast and go through some of the slides faster than I intended. But if you have any question, or if you want to send me an email after that, please feel free to do so. Thank you very much.
Thanks, Namar. Peggy, would you like to share your screen?
Sure, I'm happy to be here to share my thoughts. I have a slightly different approach here, where I'm hoping to talk more about sort of a perspective of how these different conditions are interrelated, and a methodology type approach. So let me go to this slideshow. All right, are you all seeing the right version of my slides?
Yes, looks good.
Great. So just some thoughts about how these complex disorders are interrelated. We previously heard that all three increase with age, and I think it's important to know that these are often things that when people think of what an older, potentially infirm person looks like in their head, they think probably of sarcopenia, osteoporosis, and frailty, even if they've not articulated it that way. If you ask a young child to draw a picture of an older person, they're often someone who's hunched over, who's smaller, who moves slowly, who is exhausted, all of those things that meet these, the general criteria for these definitions. They also all have, tend to have very complex definitions. This is definitely true for frailty and sarcopenia, and has become somewhat true for osteoporosis. And I'll get to that in a bit. Because of the complexity of these conditions, they also, to some extent, share similar concerns about measurement issues. Now, these measurement issues are somewhat different for each condition, but I think it's important to sort of review them and highlight why they may be similar and way different. So many people probably are aware that bone mineral density, particularly from a DEXA scan, is used as a proxy for bone strength and is used to identify, one of the methods of using to identify people for to recommend for treatment. People often dislike BMD as a risk factor for fractures for a couple of reasons. One reason is that it's just a proxy for bone strength. It's taking the differential absorption of X-ray through the person, creating a two-dimensional image, and from that approximating a risk of fracture. We also have probably heard things like many people who fracture don't actually have osteoporosis by BMD, so there must be something wrong with this measure. On the other hand, I think it's really important to note that BMD as a risk factor for a disease outcome in general is actually really good. So bone mineral density, the risk of fracture for those in the lowest quartile of BMD, for example, have about a 10-fold increased risk of hip fracture compared to those in the highest risk. And this compares very favorably to cardiovascular biomarkers for risk of cardiovascular outcomes. For example, lipids or hypertension for cardiovascular disease, those tend to be only about a 2 or 3-fold increased risk across quartiles. So as much as BMD gets a lot of flack for being only a proxy for bone strength, it's actually not bad as a risk factor for fracture for a variety of reasons. Another measurement issue that may be just unique to sarcopenia is that lean mass has for many years been a proxy. This should say a proxy for muscle mass, but it's not actually a measure of muscle mass. It's a measure of lean mass. And lean mass includes not only muscle, but also fibrotic tissue, connective tissue, skin, water, etc. So lean mass doesn't measure muscle mass directly. And unlike bone mineral density as a risk factor for hip fracture, lean mass on its own is usually not related to poor outcomes in older people. So it's largely unrelated to fracture risk or to disability or to risk of hospitalization or other poor outcomes in older people. One of the other measurement issues that happens occasionally in frailty and sarcopenia in particular is that the common definitions that are used are sometimes implemented in a way that makes them flexible, which could be useful in a clinical setting because then you don't necessarily have to have the exact measurement that was available to develop that definition, but it causes a lot of issues with being able to define the condition the same way over and over and over again. Right, next, let me try to advance my slides. Okay, here we go. So I would say that sort of in a very bad paraphrasing of Tolstoy is that all simple disorders are the same and all complex disorders are complicated in their own way. And so this is where I think there's some differential or some differences across these conditions. So osteoporosis, of course, sometimes we can see it when it happens, when someone has a hunched over posture, but often you don't know if someone has osteoporosis or not. And the somewhat at times stochastic nature of falls and fractures can hide the risk of true disease. And by that, I mean, you could have two people who have the same bone strength and the same general risk for falls, and one person just happens to fall in the direct exact way that fractures their hip and the other person doesn't. And does that mean that the person who didn't fall, do they not have osteoporosis? Do they need to be treated? And the idea of a primary prevention for an outcome that they may or may not even have the risk. They don't have the fall. They may never have the risk to have it. It makes it a very complicated disease to treat. Frailty is also really challenging. It has that I know it when I see it phenomenon, as I sort of described before, where people sort of picture in their mind what someone clinically looks like when they have frailty, what they look like physically. And oftentimes that's difficult to define precisely. And then in sarcopenia in particular, we have so many competing definitions that often the definitions are so diverse from each other. We're really using different rulers to measure what we think is the same underlying condition, and that can lead to all sorts of issues. So the only have one primary data slide. This is from Alexandra Mayhew's dissertation work, where she did this amazing synthesis of hundreds of studies to look at the prevalence of sarcopenia by varying definitions. And in this project, she found that the prevalence of sarcopenia, depending on the definition used, ranges from 10 to 40%. That's a huge confidence interval for understanding what the true underlying condition is. And you'll see that it's not necessarily clear even when there are different measures of lean mass. That's all these ALM measures, that those still vary quite substantially. So when I hear people in grants say the prevalence of sarcopenia worldwide is estimated at X, I'm always a little confused because I don't know exactly what ruler they're using to make that decision. And if we believe that this is a true underlying condition, there's just no way that this prevalence variation can be true when the rulers are different. It could potentially be true in different, race, sex, ethnic, and age subgroups or disease conditions, but not across generally healthy adults using the same measurement tool. All right, so I have a little picture of that just to remind myself. But remember, if we think someone is strong, they should be strong and muscular by every definition. And if they're weak, they should be weak and have little muscle by different definitions. All right, so that's a little bit bleak. Those are the problems. So what are the ways forward, and how do we move forward with this? So one, sorry, I'm having a little hard time. There we go. Advancing my slide. So what's the way forward? So for research, this can be somewhat more straightforward. So osteoporosis, the field of osteoporosis actually was able to make a good contribution by figuring out how to get across some potential limitations. So you may or may not know that bone mineral density measured by different densitometers, like for example, those made by Hologic or Lunar, actually give different absolute values for bone density. And one way they were able to overcome that is to develop what they consider T-scores. Sorry, it's in the evening in the West Coast and my son just opened the door. So there's a chance you may get to see my children during this presentation as well. So T-scores were developed to be able to compare bone mineral density levels across different manufacturers. And that solved one of the major problems in osteoporosis. And maybe something like that will help us move forward. In research, we've also, in sarcopenia in particular, been trying to come up with a common language and terminology so that we're really precise with what we're describing. And part of our work with GLIS, which is the Global Leadership Initiative in Sarcopenia, has been to develop a glossary of terms to use. One example is the term muscle quality has numerous definitions and meanings in the literature. And having people, instead of saying muscle quality, instead describe exactly what they mean. Do you mean specific strength, for example, which is the strength of a muscle divided by its size? Or do you mean muscle density from CT, which is thought to be a surrogate of muscle fat infiltration? So just making sure that we're using that term in that we're avoiding muscle quality as much as possible and using a more precise terminology. That also has spread to frailty with the two major definitions that have been proposed, the original Fried phenotypic definition and the Rockwood deficits accumulation definition, and to ensure that there's precision across those different measures. All right, so often, and the last thing I'll say from the epidemiology perspective is about sarcopenia in particular, and often we hear at meetings or in the literature that one challenge in sarcopenia is no drug companies are developing pharmaceutical agents for treating sarcopenia because there's no agreed upon definition. I would say that maybe it's the other issue is that there's no agreed upon definition because we don't have a treatment and importantly, a mechanism of action that will firm up exactly what should be in a definition of sarcopenia. So imagine that there's a pharmacological intervention that makes muscles contract more quickly and more forcefully without changing their size. In that case, a definition of sarcopenia wouldn't necessarily need to include muscle mass as part of it. If that intervention also improves strength and physical performance, then that might be part of sarcopenia. On the other hand, if there's an anabolic agent that increases both muscle mass and strength, then it becomes much more likely that muscle mass itself would be in a definition of sarcopenia to identify people who would benefit from treatment. It also depends a little bit on how studies are designed to treat this condition and the outcomes associated with sarcopenia. And so I think that until there's a really clear pharmaceutical definition, it's going to be really hard to come up with a single definition that will work in every single setting. Of course, we know that exercise and diet can have impacts on sarcopenia in particular. However, those tend to be very non-specific definitions. And so I'm not sure that that's going to be enough to drive a new definition forward. All right. Thank you very much for your attention. I appreciate it. And I'm interested to hear what Jesse has to say now.
Thanks, Peggy. So yeah, Jesse, take it away. Share your screen.
That I'll just move the screen. You've got that there? Great. Well, thank you, Peggy and Itamar, for excellent talks, and thank you to the EMCR of the Society for inviting me to speak. I'll be providing some background on the clinical aspects. So these icons represent the key points I'm going to be discussing today. First, I want us to think about the lens through which we view these problems and the biases we might bring to that based on our experience. So we've fortunately heard from people from different fields focusing on similar problems today. Consider your own lens and your biases you might bring to this and have your thoughts challenged in some ways. I'll then be discussing the intersection of these challenges because it is continuous, and also consider the analogy of the forest and in the trees and consider the problems at a granular level and also a macroscopic level. Can I just make sure that you've got the slides and not the presenter view? Is that right?
Yeah, it looks great,
Yeah.
Jesse.
Okay, thanks, Pete. All right, so first of all, I think it's important to think about what our goals are. So I think when we're approaching any problem, we've got to consider our goals in mind and whether they match with those who we're trying to provide that care for. So I think a useful way for clinicians and beyond to consider this is that we're not necessarily aiming for maximum longevity with our interventions, although that is the goal of many. It may not be my own personal goal, but we're really looking to extending the quality of our life represented by quality adjusted life years and reducing the time spent living with disability, or the disability adjusted life years are the way to measure that. So keep those goals in mind as we go through the approach. So for eons, the medical approach to problems has been somewhat reductionist. And in more recent times, with the growth of geriatric medicine, the view has been somewhat more expansive. And I'll explain what I mean by that. So a reductionist approach from a clinical perspective is where you're trying to reduce the problems that you experience down to a single cause. So keeping causality at the heart of the problem, which is very important for scientific thinking. So if we think about a person who has presented to an emergency department and they've presented with a couple of weeks of shortness of breath, they've got some leg swelling, you listen to their lungs and there's some crackles there in the bases, you order a chest x-ray, it shows pulmonary edema, and you order some bloods and you see an elevated beta natriuretic peptide, which is a marker of atrial stretch.
So you combine these symptoms and signs and investigations, and you distill it down to a diagnosis of heart failure, or in this case, based on the clinical signs, you'd say acute decompensated biventricular failure. So that's a reductionist approach. It's very important for getting to the heart of what's going on and being able to act and target your management. In more recent times, geriatric medicine has focused on an expansive approach, because we know with, as Itamar described, our aging population who often present with complex comorbidities and interactions between different conditions, that the presentations aren't always discrete and can't be packaged simply every time. Sir Bernard Isaacs coined the terms geriatric giants, which describes these large syndromes that are quite encompassing, that often older people may present with. So if we think about another scenario where an older person might present with a fall, an expansive approach considers that syndrome as a window into looking into what other problems might be contributing to that, and what we can optimize to both react to the situation and treat what we need to, but also think about preventative action into the future. So in this situation, a presentation of a fall as a syndrome, if it's considered that way, you can think about contributing features like sarcopenia, sensory deficits like vision and hearing impairment, footwear, and environment. And you really need to draw on your colleagues, nursing, allied health, through a multidisciplinary team model to address the multiple problems that people present with, to reduce the risk of those things happening in the future, and to intervene for future prevention. So to summarize that way of thinking, so the traditional reductionist approach is a heuristic type of thinking where you're relying on pattern recognition. And more modern approach to geriatric medicine thinking is typically more expansive. So this, I think, is an oldie but a goodie. And the caveat to this slide is that you'll see I've crossed out muscle quality in concert with Peggy's comments on the problems with that term, but also reflecting the terminology presented by the GLIS in their recent paper. I find this conception quite useful in terms of discussing how sarcopenia and frailty differ to clinicians and how they're similar. And often there's a lot of skepticism that comes from clinicians about, well, are they different things? Are they measured in similar ways? Are we just calling sarcopenia something to create an entity when we don't necessarily need to? And the way I like to conceive of these and where osteoporosis fits, well, it can span all of these, both frailty and sarcopenia, but it can exist outside of them as well. But as Itamar described, there is significant overlap between the pathological processes. Similar to as Peggy described, the way in which frailty is defined often links it with sarcopenia. If you use the Fried's criteria, there are similar features with many of the common sarcopenia definitions like muscle strength and weakness. And you can see here that is represented the intersection of physical function impairment. But if you use other definitions like a frailty index, that overlap might differ dramatically, and there have been numerous studies representing the significant overlap and the mismeasurement and disagreement between definitions that occurs depending on the definition you use, which Peggy showed in her data slide from the Mayhem study in 2018. A way I like to argue with clinicians about how sarcopenia differs from frailty is the extent to which we can intervene to prevent decline. Now, if we just focus on frailty, not the physical function impairment component, while we can optimize factors, and there is good evidence to suggest we can slow down frailty, once people have acquired deficits, you can't necessarily eliminate those deficits. You can optimize and potentially minimize the impact they have, but you can't eliminate them. And so that's why I think it's quite useful to conceive of sarcopenia in terms of what we can slow down and reverse, targeting those elements of gait speed, balance, and muscle strength. And that seems to be more of an effective way for clinicians to understand how these syndromes overlap and are related, but also how they differ. So how does thinking expansively work in practice? I've already given you an example from someone presenting with a fall to the emergency department.
here I've got a femur, and there's a fracture of the proximal femur there. And as Peggy mentioned before, this person may have osteoporosis. Well, they do now because they've got a fracture, and that's how it's defined. But preceding this fracture, they may have been osteopenic, or they may have had normal bone density. We know that the majority of fractures worldwide occur in people that have osteopenia, simply due to the population distribution. So if you think purely reductively, and this is a bit of a subtle jab at our orthopedic colleagues, who there have been many memes created about fracture that I need to fix, which many of you may have seen. So you can fix the fracture, but the fracture belongs to a person, and that person has a whole range of personal factors, environmental factors that need to be addressed if you're going to think expansively, not just acutely into hospital setting, but when that person moves back to the community. So across all of the guideline definitions about how you manage sarcopenia and frailty, there are common themes. Now, these aren't specifically written in this way, but summarizing, this is how I conceive of them, is first you've got to identify contributing factors. So as I mentioned in an earlier slide, identify all the problems and features that you can do something about, and you will rely heavily on your team, your multidisciplinary team, to support in that identification. You've then got to optimize all of those things that you're able to, whether that's addressing sensory deficits, whether that's getting appropriate footwear, getting services into the home. And finally, you've got to act, and you've got to think preventatively. And with the case of sarcopenia, if you identify that that's a problem, and it's most likely going to be, that involves targeting exercise and calorific intake, particularly protein intake, and working out ways in which to get the individual in their social context to be able to engage in healthy behaviours. So when we think about exercise, it's useful to compare it with what doctors most commonly do, is prescribe medications. So in a Cochrane review, now almost 10 years old, it was found that patients take medications far less vigilantly and are less adherent than us doctors often think. I know from my own clinical practice, my patients will often tell me enthusiastically that they're taking all their medications, but you ask their family members and it's quite a different story. In med school, so it's 50% of prescribed doses is what this Cochrane review found that people actually take. That doesn't mean every person will take half their medications. Often you'll have people who are very adherent and people who are barely adherent at all. In med school, we were taught the mantra that 80% of people take their medications 80% of the time. I don't know where that came from, but it's something that was burned into my memory. When we compare that to exercise adherence, well, the clinical trial setting, while it's proven benefits in sarcopenia and frailty, it doesn't reflect real life, as we all know, and that people are far less typically adherent in real life than they are in a trial setting. In a trial setting, you get people who are actively engaged, who meet eligibility criteria, and usually have the financial and social resources to engage in extracurricular activities such as clinical trials. But this study in BMJ Open found that 1 in 5 people are fully adherent with exercise prescriptions, and 2 in 5 are partially adherent. When I discuss with patients, and encourage my colleagues to do the same, is to consider exercise as a prescription. Not to say in that authoritative way that the doctor prescribes, the patient does. We know that's archaic, it doesn't work. But in terms of the way we conceive of how a person can adhere to a medication and how we follow it up. So for a prescription, you're going to prescribe the medication, you're going to talk about the benefits and the risks, and you're going to work out a plan of how to monitor and follow up the impact of that medication. Often when clinicians prescribe exercise, they don't conceive of it in that same frame, and don't follow it up or don't discuss with people the nuances of it. So therefore, naturally adherence is not as effective. So consider exercise a prescription, but there's more nuance to getting people motivated to actually engage. You may be familiar with the analogies of the carrot or the stick, the carrot being an enticement to undertake something and the stick being a punishment. So in communicating this with our patients, you've got to think about what that individual values and preferences are, match with their goals, and then also sort of think about what kind of person they are and how they'll respond. And you can get a bit of an idea from that in communication with them. So for example, a carrot, so an enticement to engage in healthy behaviors, including exercise and good diet, is that you'll have improved energy and strength, you'll maintain independence, and you might be able to dance the funky chicken at your granddaughter's wedding next year. Where you compare that to the stick analogy, so you're describing the negative consequences of not engaging in healthy behaviors that can be a little more direct and say, get weaker and break a hip. You'll end up in a nursing home, and that's the thing that people fear most. Or you won't be able to go on that caravanning holiday you've been planning so much. For so long, my personal preference is to take the carrot approach. And I find really useful in these discussions is not a conversation about sarcopenia or frailty per se. It's more on the cognitive side of things. What people often fear most is, one, developing dementia, and two, losing their independence and residing in residential aged care. And we know that exercise can have major preventative impacts on cognitive decline across the lifespan. So that's usually the stronger motivator rather than sarcopenia or frailty per se. So as I said, with a prescription, you've got to measure the response against the goals, and you've got to monitor changes. So you have to look for that, what we call meaningful change. We know that grip strength doesn't really respond well to exercise intervention, but walking speed does. So that can be measured over time, and ongoing encouraging and motivation. So then the next layer is, well, these barriers, these interventions only work if the barriers are addressed for that person. So I spoke about, I put the icon earlier about the forest and trees. And I think before getting into this with respect to patients, I also think it's relevant to think of this analogy with respect to your role. And I'm talking about the attendees. So we'll have people here from basic sciences, epidemiology, clinical sciences, clinicians across a range of disciplines. And I think everyone from the basic science end through to the clinical end, and that whole spectrum of translation is really important to the bigger picture of providing care for our patients. So while I've focused on clinical, without the work of Itamar and Peggy and their colleagues, the clinical, the way you can provide and deliver evidence in practice wouldn't be there. So if we're thinking at just the tree in the forest, we're thinking about the bone, and we're thinking about the fracture. But that fracture, as I said before, belongs to a person. And people are complex. They're different and highly varied. And this is a representation of the social determinants of health. And when you're thinking about how people will respond to an intervention, it's very important to think about that person within their context and the barriers and enablers to them engaging in healthy lifestyle activities, including exercise. There may be a range of factors that we need to consider. And we know that the most basic things like good economic resources, access to education and public health are some of the most fundamental enablers of a healthy lifestyle and healthy longevity. While I don't expect those in the Zoom room to immediately be able to change political structures to advantage those that have significant socioeconomic disadvantage, it's always important when considering our interventions and the things that we're developing, how can we reach those who are in most need, and what barriers are there to reaching those people? So these are a couple of papers. The QR codes will take you to the full text. So this is some guidelines that we've developed through consultation. For the first with consumers in Australia and New Zealand, that's for community-based, community-dwelling older adults, and the second is hospital-based for sarcopenia and frailty. And that's all I have.
Thank you so much, Jesse. I'll pass over now to Ben Kirk, who's going to chair our panel discussion, and encourage attendees to ask questions. We have about 20 minutes left for that, so thank you all.
Thanks, Jack, and special thanks again to all speakers for those very informative and thought-provoking presentations. So as Jack said, we will now commence the Q&A. So I encourage everybody to get engaged, and we also support collegial debate. Don't be afraid of pushing back against something and expressing your opinion. You can do that through the chat or by unmuting yourself. So we can go ahead now if we have any questions from anybody. I think we have one in the chat here to start off from Catherine Hewitt. She asks, are there any studies showing a link between bisphosphonates and insulin sensitivity and muscle mass? I think she's referring to. And I think this refers to Itamar, as he was talking about the possible link between using denosumab in treating RANKL expression in bone and muscle and osteoporosis and sarcopenia. So maybe if you have an opinion on that, Itamar.
Right. Sorry. For denosumab, thanks for the question. For denosumab, there is some evidence, particularly in animals model, for both insulin sensitivity and muscle mass. The insulin sensitivity was shown both in animal, the whole animal, and C2, C12 cell lines. Zolondronate, I don't think so. As far as I know, and from the search that we did, we couldn't find any supportive evidence to improve insulin sensitivity or any effect on muscle, and also not in people. So when you looked at a randomized study that did a secondary analysis on muscle mass, as far as I know, maybe there are other studies that you did, so I'm not familiar with any study that shows a significant improvement following zolondronate. So that's why I said a lot of the studies that to date are in animal models or cell culture models, but not to less extent in humans. And in the humans, in the denosumab case, there is a lot of differences in the intervention, in design, and as I said, we need to really take that with a grain of salt, because none of those studies was directly designed to look at that. It's all secondary analysis and things like that, so I wouldn't take that now as too strong. It needs to be invested to explore further in the future.
Thanks, Itamar. And just continuing along that, in terms of mechanisms of aging and diseases, we know the geroscience model posits that we should study aging kind of holistically, and it proposes a number of different mechanisms, one of those being inflammaging, like what you talked about, chronic inflammation, and you nicely presented the relationship between chronic inflammation and perhaps osteoporosis, sarcopenia, and frailty. So my question is, do you know of any potential drugs that could target inflammaging and possibly all three of these diseases simultaneously? Or is there something more upstream that we could target that causes inflammaging as well with a drug, in terms of, let's say, cellular senescence and some other in vogue treatments that are on the market for cellular senescence?
Currently, if I would know on an effective drug that can target all that, I wouldn't be on that phone call right now. I would probably be somewhere else. But so the answer is no. It's one of the problems that we have, and we sometimes like to ignore it, is the body is quite a complex environment, and all organs are communicate with each other. One of the things that sometimes we keep studying separate organs, so organs separately, without taking into consideration what will happen to other organs while we are treating one of them. Inflammation is one of them, and there are some drugs, glucocorticoids, if you like, that will help in suppression of inflammation. However, it has such a severe side effects for other organs. And we know that some of the medication for diabetes that can improve glucose can also affect lead to or increase the risk of osteoporosis. So we need to be careful. It needs to be really specific. And that, I think, one of the challenges, and why a lot of things that people shows work in animals and cell culture are a bit less effective in humans. So I don't know on any drug that can, maybe there is, but I'm not aware of, that can do it in an effective way without doing any damage to other organ.
Yeah, just very quickly.
Other than exercise.
Sorry, go on.
Yeah, I was going to add two things. So 4 years ago, there were a number of early phase trials of senolytics that were flashy when they started. And I'm not seeing any of them come out with positive findings, which suggests that either recruitment was delayed from COVID or they didn't find stuff that was, curing all diseases. I would also say that I think there are drugs that have recently been approved that may actually impact all of these outcomes. And it's the GLP-1 agonists for weight loss, because they seem to have a whole host of diverse effects and improve function in people. but they cause weight loss. And in older people, the safety isn't totally clear. There is a concern about prescribing weight loss in older adults, even through behavioral interventions, which, as we all know, don't really work that great in terms of actually getting people to lose weight. So I think there's some outstanding questions about how far-reaching these weight loss medications might be in treating a host of age-related outcomes. And of course, this goes back to bigger questions that we're not going to be able to address here. For example, is obesity the cause of these outcomes or something that travels along with the other conditions?
Yeah, that's exactly what I was wondering, or my cogs were going in relationship to senolytics and targeting cellular senescence, and those cells that neither proliferate or die, they cause inflammation, and that could cause bone and muscle loss. So that's what I was wondering, do we see any opportunity for senolytics in that? But anyway, I'll shut up and we'll go to another question we have here from Paul Friedman. He asks, what happened to arm anthropometry? In 2 or 3 minutes, I can measure mid-arm circumference. I presume he's relating to sarcopenia and muscle loss, and that being a proxy for it. Maybe Peggy or Jesse, would you have any opinion on the sensitivity and specificity of using such a measure, mid-arm circumference, for sarcopenia or for any of outcomes in terms of fault fractures?
I can take that one. I think part of the issue with those measures is they're highly variable, both within and between the people who are doing the measures, and that they can also be difficult to interpret. Well, on the margins, people with larger arms tend to have more muscle mass. That's not always true. We know obese people have larger muscle mass and relatively less we'll have larger muscle mass and more fat. How much muscle, it's hard to tell from caliper measures. We find that, for example, we do waist circumference measures as a proxy for obesity, for example, even with really precise protocols and trained clinic staff, we still see really huge amount of variation. So I think that's one of the reasons that the caliper methods haven't been as widely adapted.
And I can add to that from a clinical perspective. I suppose a clinical approach to these sorts of problems is your investigation or examination going to change what you do, or is it for mere curiosity? If you've got such high inter and intra measurement variability for something, you're not going to be able to accurately predict something, and it's probably an outcome, and it's probably not going to change your management if the person is already deemed sarcopenic or frail. Your intervention is going to be the same. As I said before, you're going to identify the reversible factors and intervene in a way that's pretty simple: exercise and dietary intake.
Thanks, Jesse. We have a question from Julie here for Jesse, and she asks, how do you think we can improve exercise prescription in the clinical setting?
So this is the I don't know, billion plus question, because that no one's been able to successfully answer. I don't think I'm going to give you any more pearls for this. I've found the most effective approach when I'm working privately and where you're a single clinician is to involve more people, so and motivate. So using those nuanced approaches that I described, thinking about the whole person, has been speaking about the role of geroscience, but thinking about the whole person in their context and what sort of motivating factors will work for them and what barriers exist to them engaging in exercise. That's at an individual level. We need to rely on our systems and our colleagues, allied health, to be able to enact and carry out the exercise prescription, whether that's in group settings, individual settings, remote-based exercises, and also have good public spaces for people to be able to engage in exercise in a free and accessible way. We know that in settings where exercise opportunities are offered regularly, it can become part of the culture. You'll see this particularly in Korea and Japan, where there is significant longevity. There's lots of public spaces, and you walk around and see older people doing exercise in public spaces all the time. And so when people have visibility and access, it really changes the culture around that as well. So from an individual level to a public health level, there are lots of things that can be done and improved. And we know that doing that actually, it's a relatively cheap intervention to increase people's engagement in exercise, but saves tens of thousands of dollars of healthcare money down the track.
Can I just, jump in, because if I will not say it, my wife will kill me. I'll just share a screen for a second. So the reason why I'm saying it is because Pazit is now working with a lot of, so Pazit, my wife, working with a lot of councils, community counseling, and what they're doing is actually they are building senior exercise parks, and they have a lot of clinical trial, including with people with dementia. So they're working in nursing home and so this is in public school and public areas next to playgrounds of kids, and then the grandparents can come with the kids who play on the kids part, and then the older adults playing in a exercise park that is designed for them, and they have many of them now across Melbourne, and built one in Perth and in New South Wales. So I think that this is one of those ways to engage older adults in the community. I think that exactly what Jesse said is that there is that what the council are doing is the social aspect of that. So they're not just coming here to do the exercise, but also they have interaction with other people. This is in a nutshell. Thank you.
Thanks, Idemar and Jesse. I have a question from Thomas, if you want to unmute yourself, Thomas.
Yep. Thanks, Ben. I'm exercise physiologist from up in Sydney, up in Canada. I work for a seniors gym here. With exercise physiology, we've got a lot of really clear guidelines for prescribing for osteoporosis. A lot of research has been done. Less has been done with sarcopenia. And I'm just wondering, we know that there is a lot of exercise research looking at different modalities of exercise and different exercise variables in younger populations, specifically looking at bodybuilding, athletic populations, strength training. How comparable are those findings to an older sarcopenic phenotype?
I think it's difficult because the volume and intensity of exercise in older people in general is so much lower. So if you look at the LIFE study, for example, which was a walking exercise to prevent mobility limitation, it was a randomized trial across the United States, and it was a very similar trial was done in Europe in the SPRINT-T trial. Both had people walk primarily as their exercise for 150 minutes a week when they were previously sedentary. And it reduced the risk of mobility limitations, but only by about 20%. So it wasn't perhaps as intense as an intervention as they had hoped. And the effect in both of those studies was much more modest in the people who had better function to begin with. So it suggests that there needs to be specific prescriptions or recommendations based on not only age, but also on ability to really have distal outcomes. In terms of sarcopenia, it's not clear what outcome to have. Do you want to just change if they have sarcopenia, yes, no, or do you want to reduce the risk of falls or disability or hospitalizations? And so I think that's part of the reason why we don't have as much targeted at a specifically for sarcopenia, is that it probably needs to be towards some other like clinical outcome as opposed to just a definition of sarcopenia.
Thanks, Peggy, and thanks, Thomas, for that interesting question. Jesse, I know you have to leave soon-ish.
So I can just add to that briefly, if that's okay. So on a practical level, in the absence of any sort of clear prescription, combining, and we're thinking about osteoporosis and sarcopenia here, I've found the most useful resource that I provide to patients is from Osteoporosis Canada. So it's the 2 Fit to Fall or fracture exercise, which combines the 150 minutes of aerobic exercise a week, as Peggy described, but also more functional based exercises. That's a print off in a PDF form that people can do at home. And then on a practical level, when we're thinking about risk of cognitive decline, the SING test is a practical way that people can understand the level of intensity of exercise they're required to undertake. So that means that you've got to 3 times a week get puffed enough when you're exercising so that you can't hold a note and sing. And that's been shown to alter the regulation of glucose in the brain and have an impact on cognitive function down the track. Very modest, but I think that's a really practical way that people can understand the level of intensity required.
Can I just, very quickly, I will highly recommend you to go and look for Cassandra Smith's paper about resistant training and for older adults, and also what the effect of the definition of sarcopenia on the prescription of resistant training, because she's reviewing the guidelines for resistant training for older adults, and then older adults with comorbidities or other diseases such as heart failure and so forth. And I think that will give you the answer that you wanted, published a couple of years ago.
That was
I agree.
Cassandra Smith. Sorry, Isabel? Was that the name? Cassandra Smith.
The name is Sarcopenia Definition. Does it really matter? Implications for resistant training.
Thank you.
Yeah, I agree. And we there's definitely more scope in our field in sarcopenia and frailty, age-related conditions, and also in hospital settings to try identify the minimal dose that's effect in terms of exercise and improving the outcome and length of stay and things in inpatients. There's still an area in the exercise physiology world I think we need to do more research in. So I'm checking, is there any other questions here in the chat at present? Peggy or Jesse, the question for you. Can osteoporosis, sarcopenia, and frailty, do you think they occur in parallel, or do you think they exist on a continuum, with some representing more advanced stages of diseases, i.e. frailty at the end? And then at the start of the continuum, there could be bone and muscle loss, i.e. osteoporosis or sarcopenia, leading to frailty. Or do you think they're all part of the same thing, and they're just 3 concepts we have at the moment, and really they're just one age-related condition? Yeah.
I'll go first. I think that it's probably, unfortunately, depends. I think in some people they're very closely linked, right? Regular wasting will result in muscle loss and bone loss and all the other pieces of the frailty syndrome, accumulation of deficits or exhaustion, slowness, weakness, all of that will happen together. There are certainly cases where people have osteoporosis and a higher risk of fracture where they're not necessarily wasting, and vice versa. People may have weakness and low muscle mass without having osteoporosis. So I think it depends. I think it's probably more likely that they tend to occur together or be steps towards each other and getting worse than they are totally independent. But I think both have some they both overlapping. It wasn't quite as concrete as I think you were hoping for, Ben.
Oh, no, this is appreciated opinion for sure. Jesse?
Well, I think Peggy's comment really reflects what we see in clinical practice too. So I can't really expand on that. If I tried to, I'd just be mansplaining. So I really think I agree with what Peggy has said about that. Peggy used the analogy chicken and the egg, and Matteo Cesari's paper that I presented again before from 2014 uses that same analogy when considering what comes first, sarcopenia or frailty, and how they interrelate, and thinking of that chicken or egg analogy I think is quite useful to frame that thinking.
Thanks. And just going back to the exercise prescription question, I remember a beer before, Jesse, we were talking about how do we increase exercise adherence rates in older adults and those with frailty and sarcopenia. And you told me an interesting words of wisdom was what you tell patients is, well, if you don't exercise, you might lose your mind. And that was more important and graphic to them versus losing their muscle or their function. Is that true? Am I quoting you correctly?
Well, yeah, the theme is correct, but I wouldn't use the terms "lose your mind." Not
that far ago.
But yeah, no, certainly, I think that's a stronger motivating factor is the cognitive side of things. A simple way, and it probably doesn't reflect what happens physiologically to a degree, but for people when you're requiring a simple explanation for people with cognitive impairment. usually say, like, you've got to get out and exercise, get your heart rate up, get a little bit puffed. That helps flush out your brain, flush out your mind. And that seems to be a visual that people can relate to. And yeah, I second those things about progressive resistance training. I might not have used those words, but that's always the first part of the prescription.
Thanks. I'm just seeing here if we've got any other questions. Please feel free to raise your hand or unmute yourself if you do have any questions, anybody.
Yeah, just one clarifying thing for my comment about exercise prescription. There are things that improve muscle strength, for example, in older people. It's really clear that no matter how old you are, muscle strength will improve with resistance training. Exactly the specific volume and intensity isn't, I think that's probably still up for debate. But in terms of improving more distal outcomes, that's where the evidence base is a little bit lacking. So just preventing further disability or preventing hospitalization, preventing admittance to skilled nursing facilities, for example. Part of that is because those are huge studies that would be really expensive to do. And so much of the data relies on observational evidence, which is, plus or minus, could have some biases intertwined in it. So just to clarify, I'm not saying that there's no evidence exercise works. It does. And some of it is quite well evidence-based, but not all of it for those big outcomes that are harder to study.
Thanks, Peggy. That makes sense. I'll flip it again and go back to more basic sciences, biological questions. And this one is aimed at Itamar. So we know chronic inflammation with aging, or inflammaging, is one of the geroscience pillars that the NIH posits that could be involved in aging. But I know some scientists think that inflammaging isn't actually a thing at all, that that the inflammation seen in observational studies could actually just be explained by residual confounding. So other illnesses, other people think that inflammaging could be caused by increase of fat into the liver, or it could be due to the leaky gut phenomenon. So my question is to Itamar, what's your opinion on this? Yeah.
Well, my opinion is that probably a lot of people's opinion depends on the grant that they are submitting and what they want to be the narrative. If to tell you the truth, I think aging is aging. I think that if one of the consequences of all of that, and this is including the inflammatory story and other stories, is that probably the human body was not supposed to live beyond a certain age, and we stretched that a fair bit. And the longer that we live because of medications into the future, probably we will have even probably diseases and things that we're not even familiar with them now, just because we never stretched the life expectancy. We were never designed to stretch the life expectancy so much. Whether inflammation is the drive of the changes in the molecular changes with aging or not, I mean, that is a debate that people can go on now for years. And again, it depends. You talk about chicken and egg. So if you will stop inflammation, does that mean that the people will not age anymore? I don't think so. So I don't have a strong answer for that. From my opinion, we do know that there is an increase in inflammation, particularly in older adults who are not doing exercise and have other comorbidities and other diseases. So that needs to be, I don't think that the inflammation part, at least in that context, needs to be treated in isolation, but as a whole part of a more holistic approach for prevention of aging, deterioration of the body. So I don't have a clear answer for you in regards to whether that's the driver or that not. Probably people can give you evidence for here and for here, depends on their point of view. Sorry.
Yeah, no, that it's a good answer, though. It makes sense to me. I'm just thinking, going back to what you're talking about, Rankel, and we have antibody against that in severe COPD and these conditions. Rankel expression goes up as well and everything. So I'm just thinking, should people in our field, researchers, including myself, should we be thinking more holistically and joining forces with the geroscience approach and thinking that, targeting multiple organs at the one time? But I know colleagues have tried to do that. And
Ben,
got
but you
slammed
just
by,
you see,
by
but you
Grant's,
just, yeah, but if you have COPD, that means that probably they're on glucocorticoids or some steroids to try to reduce to reduce the effect on the lungs, which by definition will have an adverse effect on bone, increase Rank-Lagan and promote of bone loss. So is that because of the COPD or is that because of the medication used for COPD? It's very, very difficult to isolate the two. But what's, it's, and then when you develop a medication for one thing, then you need to develop another medication to counter the adverse effect of that medication. And then after the age of 70 or something like that, suddenly you have people on multiple medications just because they are trying to eliminate the side effects of the other medications, which probably with appropriate exercise and physical activity, diet and all that, you can prevent a lot of those medications. So I don't know. It's a complex answer.
Yeah, for sure.
I don't have a right answer. The only thing that I can think of is, we know, and Peggy said that and wrote a lot about the importance of physical activity. The problem that we currently have is that people don't want to do it or can't do it. That I think that is the $1 billion. We don't need more evidence in regards to the benefits of physical activity. We just need now the evidence how to that people will be engaged with that. And I know that we're well over the time here, so I will not go, but it's all coming down, from my point of view, to fun and enjoyment. I mean, at some point, when you tell your kids, when my kids were small, I told them go and play outside. In other words, I never told them go and do exercise or go do physical activity. I want to go and play outside. And suddenly, during the aging process, 20, 30, 40s, we're not telling to people anymore, go out and play. We tell them go and do exercise and physical activity like it's almost punishment. You really need to do that. We need to go back to basic, and that the best exercise is the exercise that people will do for a long period of time. We don't need to think about optimal exercise in regards to the physiological benefits. We need to think about the optimal or the most enjoyable exercise that people will do. If you have an older lady that loves to dance, that should be incorporated into the physical activity routine. If you have someone who likes to play tennis or going for a hike on a mountain or whatever, that should be I highly recommend, and then I'll shut up because I really need to go to another meeting. There is a Netflix series. I actually put it on Twitter, that it's called Live to 100, The Secret of the Blue Zone. If you have of the blue zones, if you haven't looked at that, have a look at that, because that may change some of your perspective for and what you want to do research. Beautiful series. It's only four episodes, about 40 minutes each. Unbelievable. And that's exactly what they're talking about, the enjoyment of physical activity, to incorporate that into your daily routine. Maybe go to work in the garden. So people think, yeah, we are going to work in the garden, but you're, as clinician, oh no, they're doing physical activity. They just don't know that they're doing the physical activity because they're enjoying it. And I'll shut up now.
No, knowledge bombs here from me. Absolutely. I'm learning, and I'm sure everybody else is, although they're all hiding and their videos are off and they're muted. But I agree with most of that, but I push back against one thing in terms of we don't need to find the optimal dose for exercise and outcomes. I think we do, because a clinician has a patient that has diabetes, they just give them the metformin, that pill, they take X milligrams a day and it works. I think even in the acute setting and the inpatient setting, if we do get the knowledge that we give twice a week exercise and it reduces length of stay by X, then that could be the recommendation, the blanket recommendation. At least it'll be a start for something, but I totally agree with the move for purpose and all that. And those people living longest, definitely they're not doing exercises they don't enjoy. They're doing exercises in their daily life that they enjoy, i.e. gardening and things. So any final comments, Peggy, or for anybody else in the audience? No? Well, I'll just thank you both again for coming on and speaking. It's been absolutely fantastic. And I know Jesse's had off, and thank you to all the attendees as well. And apologies for our tech issues. Like I said in the comments before, nothing you wouldn't expect from a young EMCR group full of postdocs. So we're still learning in terms of science and how to manage things. And I'll pass you over to Jack And like Emer said, I'll shut up now.
Thanks, Ben. Yeah, nothing much to add from me. Just a big thank you again to our presenters and for everyone attending. Like I said, we'll share some information about once the recording's available, and also just a plug again for our symposium that's coming up later in the year. And membership for the society will include all that in a bit of a follow-up email after this event. But that's also thank you again for attending, and yeah, enjoy the rest of your day.
Thank you.
Cheers.
Thanks, everyone.